with your own QIN, work within your own states, because again, much of this work happens after the webinar ends and when you can start to work within teams to get to some solutions. Measure what you're doing and follow those measurements over time to show more success. Geriatric pain website. This is the website that I used pretty extensively during the second webinar. This is a wealth of information about quality improvement initiatives. I really will encourage you to go back to this geriatric pain website if you've not already done so. This is the section geriatric pain. You'll see on the left-hand side, quality improvement is a wealth of information about checklists. What are you doing appropriately, and are there things that you're forgetting? Little sample audits that you can do with a couple charts to make sure your documentation is good. Instructions for tracking, lots and lots of good tools in there. So I will encourage you to go back as you continue to work on your quality improvement efforts in your home. Make sure that you're using this website. Another great source of quality improvement over the next few years is going to be a change package. This is for folks that are familiar with this. This is really a main reference place to look for best practices and also really to help make that change happen in your facility. So they take some key points of essential points, and then they drive change through using those points. So a few of the team points that really fit in under pain and this quality improvement around pain is obviously the teamwork and communication around the teamwork, especially with this topic. It really is essential. Continuously changing and trying to re-improve and reinvigorate your process. And then, of course, compassionate clinical care. And we're doing a holistic approach of the patient, of the resident, that includes all of their aspects and all of their goals. So stay tuned for more information about this change package as it continues to develop. But we use this pretty extensively when we're doing quality improvement programs. So this will be another great source as you continue to improve in your own facilities. All right, well, that is basically, in summary, what I would hope that you could take away. If there's nothing else that we learned today, I think that the place that we can accept is pain is a condition that we all have, but with good assessment and management, we can have a good quality of life. And really, that's the goal. The goal is not to be pain-free for that resident, because that's an unrealistic goal for anyone. The goal is good quality of life so that an assessment can show that their pain is not severe. It can be mild to moderate and they can still have activities. So with that, I'm going to turn it over to Sharon, and we'll continue to talk a little bit more about pain assessment and certainly a lot more details to come.
Okay, thank you, Nicole. Can everybody hear me okay? You can chat in if not. Okay. Basically, our first slide up here is regarding the importance of the pain assessment. Most of you that have been through training for the MDS documentation will recognize a lot of this information. I want to start before I go through it and just really people understanding, as I think we all do, and that is pain is perceived differently by each individual. I perceive it differently than Nicole perceives it. And also recognizing that a lot of people have a low tolerance to pain, a lot of people have a higher tolerance. So all of this, of course, pain can be a major contributor to cause and decline in the patient's overall health, lifestyle. So really the key component is really understanding, getting to know that resident and understanding where their pain is and what's causing it. We know that it can adversely affect quality of life. We've seen it in our business. Can cause depression, cause social withdrawal, definite diminished self-confidence and self-esteem. We've had increase in behavioral problems, particularly in cognitively impaired or aphasic residents. I talk frequently about an example years back of an individual that we worked with for years, and we actually put them on, they had behaviors. They were aphasic, had a lot of behaviors, put them on an antipsychotic drug to deal with the behaviors, only to find out down the road a couple years later that he was actually suffering from pain, but he was not able to tell us that. So he was acting out, and once we recognized that it actually was pain, we were able to get him on a pain management program and get him off the antipsychotics. So real critical when we're looking at behaviors to first thing to check for is pain.
And Sharon, we did,
yes.
during the second webinar, we did recommend that if you're doing psychotropic medication review meetings, there absolutely must be a pain assessment component in that review, because
Yes.
just what you said, that so often
Exactly.
that may not be the case, that may not be related to pain, but since we can't rule that out in someone who can't speak to us about it, absolutely important.
Exactly. Some older adults limit their activities in order to avoid having pain. Again, you know, a lot of our folks come into us for rehabilitation, and they're not able to do their therapy sessions because they're having too much pain. They're not able to come to their activities. They're not able to come to the dining room. A lot of different things. So it's again, all of you in the audience, you're experts in this. You see this day to day. It's critical to remember. Also, reports of lower pain frequency may actually reflect avoidance of activities more than it reflects adequate pain management. And that can lead to decline in function, complications with mobility, skin breakdown, infections, all of those complications that can actually cause harm to a resident. So again, a very critical area that we need to assess, making sure that we have dealt with their pain so it doesn't lead to those complications. So basically, you know, what some of the current challenges, and again, I'm speaking to the experts, you all live this every day. We know that our patients arrive from the acute care settings frequently in acute pain, and we have no evidence of any recent pain interventions provided prior to the transfer. No evidence of adequate orders for pain management coming from the acute provider. And this definitely can cause a significant delay in our ability to treat because we call the hospitalist, they don't want to give orders. We call the specialist, they don't want to give the orders because they've discharged the person. And we also have to have the signed prescription by a medical practitioner for the narcotics. And this takes time, especially when we're admitting after hours, late evening, weekends, which most of our facilities are set up to do that. So it's important to work with the discharge planners at the hospital to ensure that we have complete orders come from the acute care. And we need to also, I recommend obtaining a report from the discharging nurse at the acute care. And I know our facilities do that, but it's having that contact with that nurse just prior to discharge would be the best practice. So that we can find out when they have their last medications, so that we will be prepared when they come into our facility. We also are always dealing with the time constraints. We live a very busy life, a lot of demands, a lot of different things that we have to assess our residents for and plan for, and we definitely understand that. What I'm going to talk a little bit about is when we really need to start talking about pain. We do our assessments on admission. I'm sure everybody, their initial nursing assessment includes questions regarding pain. The problem that I see is that sometimes we don't really do a comprehensive assessment of pain until that MDS. And so a lot of what I'm going to be talking about is how we need to really initiate that process from day one, because looking at the potential decline in the resident's function, if we deal with this from day one, it can potentially avoid some of those other complications that take a lot of our time. And then we are limited also, I have to say, we are limited directions from CMS on how we can do our interview, how we can ask our questions. And again, I'm going to talk about how we can provide some education to the patient resident prior to that first MDS so that they will have a better understanding of the pain scale. So what do you do between day 1 and 3 that can make a difference? Of course, ask the right questions and just develop that preliminary care plan based upon those answers, review of that admission orders for the pain management, and then later reminders of this conversation is helpful for the resident understanding. So we want to, again, effective pain management interventions to help avoid the adverse outcomes. And this will definitely make a difference. So what kind of questions do we ask? Are you having pain? Where's your pain? How frequently are you having the pain? How intense is the pain on a scale of 0 to 10? And that's a good time, again, that we can start talking about what does 0 to 10 mean? If I say I'm at a 4 level, what does that mean? Is this a recent onset or is it a chronic? And that's real critical. A lot of our people, again, they come in with an acute condition. They've had a fractured hip, so they're having acute pain, but they also have that chronic pain that they've been dealing with for years. That even though we may be able to manage that acute, that chronic is continuing. If chronic, what have you used to try to manage your pain? And has it been successful? What's not been successful? And it's not up here on the slide, but a real critical question is, what is your goal for your pain management? Where do you want to see yourself at with that? Some people, we will never get to a 0 pain level, and they don't expect that. They haven't been at a 0 pain level for years. So we really need to look at what are you comfortable with? What is your goal for pain management?
And as you said at the beginning, Sharon, that's probably very unique to that resident. One person has a very different goal than another. Right?
Exactly. So what we need to do, and again, whether it be for the MDS pain interview or prior to, we need to establish a conducive environment. We need to explain the reason for the interview to the resident so they clearly understand. Prompt that resident to think about the most recent episode. And we can use echo to help clarify the preferred options. But again, we need to start this process from day 1. These are the instructions, again, that's given for doing the MDS interview. But we really need to start this process from day 1. So there's a lot of different creative approaches to the 0 to 10 scale. I think, it really, if you go to a doctor's office, if you go to a hospital, an ER, any place, they're going to have, most of them are using the 0 to 10 scale, but they're all using some different explanation for it. So one of the things that hopefully with the collaborative, we'll work on something that we can use throughout so that a 4 pain level means the same no matter where you're at. That would be the optimal goal. Definitely ongoing conversation with the resident. This is something, again, we talk to that resident on admission. We have to do an admission assessment on day 1, but we don't always get to the next conversations to really look at comprehensively assessing pain until we have to do that pain interview for the MDS. And by then it's too late because CMS is real clear on how you have to ask the questions there. So basically, again, talk with that resident regarding their intensity of pain at the time of admission when administering PRN pain medication. So again, part of that team is going to be not just the resident care manager. It's also going to include your CMAs. It's going to include your licensed nurses. charge nurses. So everybody is going to include your therapist, and we'll go into a detailed list of everybody that's on that IDT team that it's going to affect. Clarify what the patient means when they're saying intensity of 8. We can do that at that point of admission because again, we haven't got to the MDS guidelines, so we can be a little bit more detailed and we can ask them, clarify what does 8 mean.
And it sounds like, Sharon, it's not only education for the resident, the nurse is learning at that same time. So
Exactly.
both
For
sides
both.
are gaining additional information. Good.
We put up a couple of examples of some pain scales. I think some of you probably have seen the Long-Baker basis. What's nice about this is it can be used for a resident self-assessment, but then it can also be used for the verbal descriptor if they're not able to use the 0 to 10 scale, the numeric scale for the MDS. It's not quite as definitive in the answers. The more I look at it, it's more of a facial, but it does at least give a little bit of education, and I think probably some people out there are using it. We've also got another one that I've included that is the resources Karen Lee Richards, who is a chronic pain correction expert. Hers I really like in the respect that it's really questions that you can ask a resident for clarification that can help them be more accurate in assessing their pain versus just, is it a 0 to 10? You can ask, they can say, is it annoying? May it have, and I may have occasional stronger twinges, or it's noticeable and distracting. However, I can get used to it and adapt. So it's put in such a way that it really can help that patient understand more what each one of these levels mean.
The reason I like this one is it really gets back to our goal of quality of life, is it starts to talk around, can I go to activities? Is this affecting my day-to-day? How is it affecting that resident's life? And I think really that's where we get back to those goals.
Exactly.
So let's take a break and see what the audience thinks about pain assessment and specifically these pain scales. I know that everyone is using a pain scale. Do you feel that the pain scale that you're using is adequate and it gets you what you need? If you have any barriers to the use of the pain scale, let us know what your main barrier is in the chat function so that we can begin to gather some areas where we might be able to help if there are barriers.
A little longer, we should give them a little more time.
Yes, we'll give you a little time. When we 3 or 4 months ago when we began to talk about pain assessment, everyone said yes, they already had a pain assessment, really didn't need any additional help with that. But once we've gotten into this assessment level and we've started to talk about how do you use it and how does that work in residents that can answer questions versus not, and so we're not sure now if maybe a standard pain scale might help. If not, is there other things around the pain scale that you might need that you don't have?
Somebody says no. Sue Todd says, residents will state a higher pain scale to get the narcotic that they want.
Yes.
Understanding of what reporting their pain scale means for the resident. I assume that is a barrier.
Okay, good. So that confirms, I think, what we've been sensing is you have a pain scale, you use it, but you understand that there's some residents that are not accurately answering the question, either because they misunderstand, they think you're going to take away all their pain medicine if they say they're doing okay, or some other misunderstanding about what the assessment really means. So that helps, and I think we'll be able to cover some of those topics throughout the rest of the webinar.
Or getting back to the education of that resident, and that is, this is what a level 10, this is what a 10 means.
Yes.
You're bedridden. You can't do anything. So if they really have a clear understanding, that may help.
And it may be something you have to continue to reiterate every time.
Yes,
Precisely.
yes,
And also them understanding that you're not going to withhold medication.
absolutely.
And yeah, there's anticipated pain. If like
And
Nicole said, if I don't say the right thing, they're not going to give me my pain medicine. Well, you have to assure them that that's not going to happen.
Right, and a lot of the language that I've seen has to do with, we want to understand how your medicine is working for you. We want to confirm that the medicines that you're getting are working, rather than something else.
Yeah, so there's some more comments here. Erica Nepper from Rosevilla, she says, I would love to compare what other sites are using for the pain assessments for prior to the initial MDS and quarterly MDS.
Okay.
Darlene Gayhart says, related to pain assessment for residents who cannot communicate. We've used PAIN-ON for all residents who cannot communicate, but surveyors are questioning this for other residents who don't have dementia, I think is what she's saying. What other tools would you suggest? The way I understood PAIN-ON is that it's for anyone who can't communicate, but I didn't know surveyors were cracking down on that. That's news to me.
I think they're just the appropriate pain scale for the appropriate resident. Just the idea that it's not one size fits all, and that there's probably 2 pain scales in any facility, one for a resident who can voice their needs and information. Is that fair?
Yes, that is correct.
I think that's probably, they don't, I suspect the surveyors don't want you to just use one for everybody,
Right.
and that to use the one that fits for that resident's needs.
And we do have that. It's again, making sure that we've got cue cards that they can read off of. And actually those are provided by CMS. So for those people that cannot verbally communicate, and then those that can point to numbers. So yeah, there are a couple already out there, but definitely will be probably part of the project, and
Definitely.
identifying what's best practice, what will be more efficient, effective.
And so for you folks that are working with your quality improvement organizations in other states, I think this is a key point for follow-up, is just pain scales. What are you using? Are they working in the facility? Do you need any further improvements on those pain scales to help the resident understand during the time that they're using them? And I appreciated the question around, using a pain scale prior to the MDS on day 1, as you recommend, and how that might be different. So those are all good points. And we'll, within Oregon and within our, with our follow-up work after this webinar, we're going to continue to focus on the pain scales.
There's also a comment from Tatiana about a language barrier. So
language
barrier.
Yeah.
If there are language barriers, I mean, part of and further in the slide, you'll notice if there is a need for an interpreter, then we would need to have an interpreter assist with that. Perhaps it could be a family member, a friend, somebody that can, I know in some facilities, maybe another staff member that is able to speak that same language. So it would be an interpreter that would be requested. Okay, so onward, planning for care. Definitely don't wait, and I can't emphasize this enough, don't wait until the admission MDS is completed. If you do at that point and haven't dealt with the patient pain, they are going to be unhappy customers, they are going to be in pain, and they're going to have a lot of concerns and complaints because of that. And definitely work with the interdisciplinary team, and which includes the resident. This is an area that, we've talked about interdisciplinary teams for years versus the multidisciplinary. But I still see, even years later, that we're still not truly adopting the culture of an interdisciplinary approach, and that's critical in this whole process.
I think with pain more than anything else, because it has so many physical, psychological, social components, you really have to have a team approach.
Exactly. You've got You've got your CNAs involved, you've got your therapist involved, you've got your nurses involved, you've got your families involved. So yeah, it definitely has to pull in everybody to have the best approaches. Um, and the next slide does in fact go through. It's actually quite a long list of people that are involved in this. And of course, that interdisciplinary team is a healthcare team that works together to solve problems using the strengths of the various team members. So of course, top on that is the resident. They know what's best for them. And I know at times we don't necessarily agree that with what they say, but they do know what works for them. Of course, our providers, our physicians, our nurse practitioners are extremely, definitely an integral part of the team. Nurses, CNAs, there's so many things that our CNAs could be doing for our residents, interventions that could be put into place that would be very, very helpful for the residents. Therapists, I know they work a lot of times, again, like I said earlier, their therapy sessions are interrupted because of the pain. Get them involved so that we can definitely, have them work with us. We work with them so that the resident is able to complete their therapy sessions without having a lot of pain. Pharmacists, very, very involved. What works best? What's long acting? What's short acting? Recommendations that we can make to their medical providers. Administrators, administrators have to be part of the team because they're making sure the whole team is doing what they're supposed to be doing. So they need to definitely adopt the culture. Social service, very, very important. Again, there's things that social service can offer on interventions on the non-pharmacological areas that can be very, very helpful for the residents. They can also help with some of those psychosocial problems and issues that can cause pain, actual pain for people. Activity directors, highly involved, should be highly involved. There's a lot of different things that they can offer. We'll talk about some of those specifics in a minute. And then, of course, any other staff with unique skills or insight, could be chaplains. We have chaplains in our company in each of our facilities. So that could be another integral part of that interdisciplinary team. So basically, our goals, of course, are hopefully to prevention, or at least getting them to a level where it's an acceptable goal for that patient. Comfort while maintaining function, and that's critical. Again, they come to us, our short stay to get better, so it's critical that they are able to maintain their function and work in their programs. And treatment. Interventions, we're looking at both pharmacological and non-pharmacological interventions. Of course, the optimal would be if we could take care of the pain with the non-pharmacological interventions. That's the best approach. But we do know that pharmacological interventions are important as well. And make sure they're individualized. Again, a lot of us have those draft care plans, which is fine to initiate, but we need to definitely then go through them and we need to initiate, individualize those care plans so they are specific to those residents, individual residents. And then we've got to review for effectiveness. So we've got to have measures to monitor. Is our plan effective? If not, why not? What can we do different? And then revision of that plan is necessary in order to achieve that resident's goals.
And it sounds like because of the elements of pain, we almost have to anticipate that the plan is going to need to be revised. I mean, that is part of the anticipation that whatever we do now, that condition is going to change over time, that it's going to need to be reassessed.
Very potentially, yes. So some of the non-pharmaceutical interventions, there's a lot of them. Some of them I hadn't even thought of. I actually sat down and talked with our director of therapy services, and she identified a lot of different areas that I might not have thought of. And then, of course, Nicole had some as well. So exercise and lifestyle modifications. Exercise, yes, it is good. It is a good non-pharmaceutical intervention. I know some say that exercise causes pain, but it is actually it is good for you. Physical and occupational therapy, including positioning, heat and cold, massage, electrical stimulation, chiropractic, osteopathic, acupuncture, and your therapist again can really, if they're pulled into that team instead of working as separate entities, really look and see what's going to be best for this patient. And again, looking at what has the patient used in the past. So that's getting to know that person and what's been effective, so that they can incorporate that into their plans of treatment. Aromatherapy. That is something that can be activities if they're doing a one-to-one with residents, or they can work with them on aromatherapy. We can CNAs. We can definitely that can be an intervention that the CNAs provide for the residents. Psychological distraction. If people get really focus in on that pain and they don't have anything else, then it's going to make it worse. So distraction is definitely good. Relaxation. What type of things can we do to help them relax more? Music, and make sure it's their kind of music and not our kind of music. What will relax them? Laughter. I know if I'm in a lot of pain and my boss comes along and makes me laugh, I'm still in a little bit of pain, but at least it's reduced the intensity some. So laughter is good. A controlled breathing, guided imagery, biofeedback, and cognitive behavioral therapy. And that's something again that can your speech therapist can really help your occupational therapist. So definitely, I don't know how many. I don't think we had a lot of therapists in the audience, but definitely take this information back to your therapy and as well as the rest of the IDT team, and work with them on different approaches, non-pharmacological, that we can use. So then the MDI, I'm going to do just a little refresher because you guys are the experts on this. So it really is a refresher, and just I'm going to put a little bit of twist on it in some areas. It basically does consist of an interview with the resident, and CMS is very specific regarding what questions to ask and how to ask them. It's all very well in print in the RAI manual. We need to conduct a staff assessment only if the resident's unable to participate in that interview. And of course, we have to make sure that we do an accurate assessment of their cognition to make sure that they are not interviewable. A lot of times we see that we mark them as not interviewable when in fact they are. The things that we do assess are presence of pain, frequency of pain, effect on function, intensity, management, control. These are all standard questions. So again, ask each question is written doesn't mean, however, that we can't prepare the resident to ensure understanding and accuracy of the answers. And again, that's the more education that we can give to that individual prior to really understand what a 7 level of pain is, then that's going to help them considerably when we ask them, what is your pain on a scale of 0 to 10, 0 being none and 10 being horrible. So that education piece, again, is so critical. And then conducting the assessment, determine what, if any, pain management interventions the residents received during the 5-day look-back period. And again, very, very important for accuracy of the MDS, and that's reviewing that medical record in its entirety, interview all staff, including direct caregivers, activities, therapists, if the resident has received any therapy during the look-back period, and answer these items even if the resident denies pain. So those are the first questions on the MDS. So have we provided any pain management interventions during the last 5 days? And of course, we are going to code no if the medical record does not contain any documentation that a scheduled pain medication was received. And we'll code yes, yes, if the medical record contains documentation that they have been received. And again, on the coding, just as a reminder for all of your MDS, that we do have to have that documentation to validate how we've coded that MDS. 100B, receiving a PRN pain medication, code no, 0 if record does not contain documentation that a PRN medication was received, and then code yes if it identifies that if the record contains documentation that medication was received or was offered and declined. And that's real critical. If we offered it and they declined it, we need to make sure that that's documented in our record and that it's coded on that MDS. So received non-medication interventions. Here's where I think we miss a lot of times in those, we think of the obvious. The therapist is given a hot pack and they let us know that in a note, but all these other things that potentially could have been offered and should be on the care plan interventions for those non-pharmacological or non-medication interventions. So again, we're going to code no if the medical record doesn't contain any documentation that a non-medication pain intervention was received. Code yes if it contains documentation. So non-medication intervention scheduled as part of the care plan and intervention actually received and assessed for efficiency. So it's not enough to just document that it's been done, but has it been effective? And it's just like your PRN medication. We have to document if they received it and was it efficient, was it effective or not. So 200, J200, should the pain assessment interview be conducted? Of course, most residents who are capable of communicating can answer questions about how they feel during the workshops, the seminars that CMS has held. They say that typically 85% of people can be interviewed, can understand, and be able to do these interviews. Information from the resident is typically more reliable and accurate than from observation alone for identifying pain. And then, of course, we will use the staff observation only if the resident can't communicate verbally with gestures or in writing. And then, of course, if B100 is 1 equal comatose, then we're going to skip because they're not going to be able to be interviewed. Okay. All right, go ahead and skip to the next one. The interview basically consists of the 4 questions. And again, this is just a refresher. You guys know this. It begins with the primary question of 300, are they having pain? And then the follow-up questions regarding the pain frequency, what's the effect of the pain on their function, and how intense is their pain. You need to conduct that interview as close to the end of the 5-day look-back period as possible. And I'm going to bring up at this point a conversation I had with one of my consultants this morning related to our short-term stay. We have a lot of people that come in for a very short period of time. One of our facilities has residents that may only be there 2 or 3 days. And we wind up doing an interview on day 2, when in fact the end of the ARD date was not until 7 or 8. And we wind up then having them show up on our quality measures. So this is real critical. You want to have it as close to the end of the 5-day look-back period as possible. Don't do it on day 2. If your look-back period, if your ARD is day 7 or 8, which typically it is, then you're going to do it day 6, maybe 5, but you're not going to be doing it the first day or 2. And I know that CMS says that you can do it earlier, anytime in that period. But if you've got somebody that discharges in 4 days and you've already done an interview, then that is on record, does get transmitted And if they're, of course, at that point, they're probably having a lot of pain.
Well, sure, if 5 days ago they were actually in surgery,
Exactly.
the look back period of 5 days isn't gonna be an accurate assessment of
Exactly.
what we're
So,
doing right now.
you know, it isn't open ended there. It's in the last 5 days. So yes, you are, it's not like it starts from day one of admission. It's the last 5 days. So make sure that, you really look at that of when you're doing those interviews. And it was kind of an aha moment for me, and I should have had that aha moment ages ago, but didn't. So now we're all having it, or I'm having it, and maybe some others out there in the audience are having it as well.
I think this has come up again in questions around, you know, when you measure that percentage of patients, you know, who is the patient population that we're measuring it on? And a couple of questions have come in around people saying, we think that there's some folks that are getting measured when they're just a short stay in our facility, and it's not a good measurement of what we're doing.
Exactly. Because remember, on your short stay, they include your admission assessment in your quality measures. Long stay, they don't, of course, because they've been there 101 days or more. But the short stay, definitely, if you identify that they're having horrible pain, frequent pain, daily pain, and at a severe level, then that is going to trigger on your quality measures. So just hopefully that will help. Okay. And just a reminder again to skip to the staff assessment if the resident is unable to answer J300 pain presence. Again, that should be very few of your people that actually get skipped. They have to definitely not be able to understand, rarely understood. So make sure that we don't do it just because it seems like the better way to do it. Okay. So prior to completing the pain assessment, again, some of this it's right from the REI manual, and that's to make sure that you establish a comfortable environment for the resident. Does the resident want or need an interpreter? And that's real critical, that we are responsible in long-term care to have interpreters available if needed. Is that resident physically comfortable and properly positioned? There's nothing worse than asking somebody if they're in pain when they are not positioned well. Can the resident easily hear you? If they wear hearing aids, do they have their hearing aids in? Are they working? As a person that wears hearing aids, that really makes a huge difference. And make sure it's a quiet space away from others. And also, has that resident recently received pain intervention? If you're right at the end of, if you're on they're on a routine pain management program, and they're right at the tail end of the effectiveness of it, you definitely want to make sure that you pick a time to interview them where they're having the most effectiveness from that pain medication.
And remember, if the intervention is a medication and it's a short-acting medication, it's going to take some time for that medicine to be in the system and working. So you can't give the pain medicine and then start the interview. You'd want to give the pain medicine and then an hour or two later, depending on the medicine, start the interview. And this is actually a common misstep that we are hearing and have been reading about nationally, as that's a place where people are forgetting to make sure the person has some pain medicine in place.
Or even if they give it, they then do the interview too close to when it was given.
Right.
Exactly.
Either too close to when it was given, or it's already worn off on the other end. So there's that sweet spot in the middle that we're trying to capture. Good points.
Okay, so just a couple other quick questions here. I mean, a couple other things under the prior slide, Nicole. Just again, explain the reason for the interview to the resident. Explain those resident choices or response choices. Make sure those responses are in large font as appropriate. Again, a lot of our people have problems with their vision, and allow those residents to write their responses if needed, and then make sure they've recently received intervention, either non-pharmacological or pharmacological. Okay, so during the pain assessment interview, again, be patient and try to anticipate the resident needs. The last thing you want to do, and I know we're very, very busy people, is to go into the room only having a very few minutes to get this interview done. So time this so that it's the best for that patient. And because you do need to be patient with them, and you do need to take time to carefully explain the reason for the interview and the response choices. You know, you want to, you know, they in the RAI manual, it very specifically states that you're to say, I'd like to ask you some questions about pain. The reason I'm asking these questions is to understand how often you have pain, how severe it is, how pain affects your daily activities. This will help us develop the best plan of care to help manage your pain. What I'm recommending is another way of explaining this is to actually have some dialogue with that resident prior to doing your pain assessment. So here we can talk about, you know, we have talked about your pain previously, have worked together to develop a pain management program based upon your needs. You currently have a fennel patch in place that we replace every 3 days. And then you also have an order for a PRN hydrocodone if needed for breakthrough. I would like to ask you some questions to see if this pain management plan has been effective for you. So you have that dialogue ahead of time, and them knowing that they are on a routine, you know, they do have a pretty good solid plan in place. They've been involved in putting together that plan. And so having that dialogue ahead of time, taking the time, the patients having the dialogue ahead of time, and then going into the questions from the MDS. Okay. Now, of course, with, again, a 300, the very specific directives from the RAI is ask that question is written, have you had pain or hurting at any time in the last 5 days? Code for the presence or absence of pain, regardless of the pain management efforts. And then rates of self-reported pain are higher than observed pain. And so then we're gonna, you know, either code 0 for no pain, where interview's complete, or 1 to proceed, yes to presence of pain, and then of course we're going to continue with the interview. And again, remembering the timing of that interview is critical. Code 9 if they're unable to answer, so they're either not able to answer, they do not respond, or they give a nonsensical response. If the resident states no to pain, complete according to instructions. They state no to pain, but staff reports observation. Make sure that you assess and address, but the patient resident has stated no. And I know that's been, you know, some of my RCMs in the past have stated, but we're giving them a lot of PRN medications. I know they're in pain. I have to code it this way. They're saying no. No, they said no, so you code it as no. It doesn't mean that you're not going to address that resident's pain in your care plan.
And that sounds like good education for your other staff, just confirming again with the staff that they may be not having any pain because that medicine that you're giving is working.
Exactly. So pain frequency, then you're going to ask the question written again, exactly as written. May use cue cards to present response options. And that's how much of the time have you experienced pain or hurting over the last 5 days? And there we go into the almost constantly, frequently, occasionally, rarely, or unable to answer. Again, that's one that if they're stating that they're having it frequently, almost constantly, then that could potentially trigger. So make sure that that is accurate information. The next slide is kind of a resident story that Nicole has put in here, which is good. Then what I've tried to do is just put in an example, and it's not written on the screen. But Mrs. B's been living at the facility since suffering a hip fracture in her home 8 months ago. She's responded well to her pain management regime, including the fentanyl patch, which we apply every 3 days. So, it's how can we talk with her about her pain? What would be an interview that we could utilize with Mrs. B? And so just an example, I put Mrs. B also has an order for a PRN hydrocodone for breakthrough. She requests a PRN hydrocodone. When asked prior to giving the medication what her pain level was, she stated is a 7. Further question to clarify could be to ask if her pain was causing her to have trouble concentrating, or if it was interfering with her ability to do her normal activities. At this point, Mrs. B responds by saying, no, not really, it's just distracting. So further question would be, would you rate your pain in a more, as a pain that's noticeable, but you could get used to it and adapt, which could be a 3 on the pain scale? She replies, yes. So what you've done there is you've done a clarification. She's given you, because you said that 0 to 10, but you've asked further questions to clarify using some of the other tools that we've showed. So just an idea. Okay, so 400, J400, CMS Directive for Coding. Again, probably says just the opposite of what I said. Do not offer definition of response options. Resident's response should be based on the resident's interpretation of the frequency options. You can use echoing to help clarify the preferred options if the resident doesn't respond according to the response scale. And of course, stop the interview and skip to J800 to complete the staff assessment if the resident is unable to respond to this item.
And much of this, it sounds like, when you're clarifying, when you're helping the resident to choose the right number, it's really, we want the accurate number. We're not trying to make it more or less. We want a good measurement of what's actually happening. And if that person understands that, that's really what this framing and this helping them get education about what we're doing early on is, so that we can be as accurate as possible.
Exactly, which we are required, and I know that is the main thing. We want an accurate assessment of that patient's pain. Okay. So the pain effect of J500, pain effect on function. Of course, the CMS directive is asked that each question is written. 500A is over the past 5 days, has pain made it hard for you to sleep at night? And then 500B, over the past 5 days, have you limited your day-to-day activities because of pain? Here I wrote an expanded question in, again, some of that dialogue prior to asking that point-blank question. I see in your chart that you have not received any PRN pain medication during the night. Over the past 5 days, has pain made it hard for you to sleep at night? It again helps them. No, I really haven't had any pain in the last 5 nights. I felt pretty darn good.
Yeah, a reminder of what has happened.
Exactly. Yeah. Another one is it was nice to see you in bingo and exercise group yesterday. It looked like you were doing very well. Over the last 5 days, have you limited your day-to-day activities because of pain? Just a couple of, again, some of that conversation prior to asking that MDS question. Okay, pain intensity. This is the big one we've talked about all along, and that's that numeric rating of a 0 to 10, which we would complete on 600A, and then that verbal descriptor on 600B. One of those scales do need to be completed if that resident is able to be interviewed. And So on the numeric, of course, the CMS directive is a reminder, is please rate your pain over the last 5 days, with 0 being no pain and 10 as the worst pain you can imagine. Part of that may also be how you say that when you're giving them that 0 to 10. Please rate the intensity of your worst pain over the last 5 days. And then the verbal descriptor is please look at this scale and identify your worst pain over the last 5 days, with 1 being mild and 4 being very severe, horrible. And again, I think through the collaborative, we can really work on scales that are more defined for that resident versus the real generic, vague ones that we currently may be using. That will be more descriptive to the patient resident, so it can be more accurate. So in summary, really, again, our goals for pain management for most patients should be to achieve a consistent level of comfort while maintaining as much function as possible. So, I often say to therapists, why don't you tell me ahead of time before they're going to have therapy so that I can medicate it before the therapy session. And of course, the response recently that I received was, well, if you have them on a good pain management program, then they should have a consistent level of comfort. So it should make a difference when I pull them into therapy. So again, going back to really care planning for that consistent level of comfort versus the high-low effect. Comprehensive assessment care planning by the interdisciplinary team is essential in providing care and services to meet the patient goals and managing their pain. And remember, it is their goals, not ours. And make sure that we have that documentation in place to support what's been done, including the effectiveness to determine if the current plan is effective or not. And so just a quick tip, and that is on the PRN effectiveness. Right now, when we give a PRN medication, we document what level their pain is at the time that we give the PRN. We also need to document that level of pain when we go in to check for effectiveness. So many times we just document effective, but that doesn't give us a true level of what was their pain. It started at a 6, but an hour later it was down to a 2. And their goal is that they want to be maintained at a level 2. So in order to really be able to document effectiveness accurately, you need that documentation of how effective it was an hour after you gave it. Okay, so we need to, last one is to basically anticipate and plan for pain assessment. Next slide. And of course, use the minimum data set, pain assessment practices as they outline, and with some of the ideas that we've given you, address environmental factors or misunderstandings that may be negatively contributing to the patient's pain assessment and management. Good. Nicole, any questions?
So as we put together the information in this webinar, we knew that it was going to be a lot of information, and we sort of joked we could do an all-day seminar probably with working groups coming up with, best practices. There's a lot of learning that can be done under pain and better pain management. We believe that within our collaborative, we're going to be taking this information that we've learned during these 3 webinars and really taking it to the next level. The last time that we worked on a project was a different topic, but it was most effective to bring groups together, to find out what their needs are, and to really develop some of these things that we've mentioned earlier, a more consistent pain scale perhaps, some help for the CNAs, that might be some quick staff training, or there might be some additional checklists that might be developed. So I want to take a moment as we sort of transition our time today from the topic of the what to the topic of some next steps. And really, where would you be interested as a team, either the Oregon or some of the other state teams, going back to your own Quinn groups, what happens next? Because this is all great information, but unless we put it into action on our day-to-day, busy schedule, it's not going to be implemented. So let's talk for a minute about tools. You know, that's a very broad term, meaning something additional that you need that you don't have. Often a tool is a piece of paper. It might be a list of, it might be the geriatric website. It might be additional training material. In previous work that we've done, we did a lot of training / fun exercises that you can do at staff meetings to help bring forward that concept of why pain is important, sort of setting the stage for what your whole facility will do and kind of changing that culture.
And maybe also even including how to have an interdisciplinary conference.
How to have an interdisciplinary conference, exactly. An example of perhaps a worksheet that can be used that everyone would use together. So be thinking about that. Of course, in your facility, what works is going to be perhaps different than another facility, but I think there's probably some very common themes that we can be developing and then sharing across the different teams. So what tools do you need? I'd be curious to hear in the chat. This is an example of a tool that was on the Geriatric Pain website. It's packed full of information. It's probably everything you ever needed all in one place, but it's very busy. And I'm not sure during your busy work schedule that you'd use this tool. I do know one pharmacist who said they used, one middle section and they use that all the time, but the other pieces they didn't use as much. So this is just one example, but be thinking about what do you need? If I was to develop something for you or according to the state of Oregon, we defined a better tool, what would the components of that tool be? So we'll prompt a couple questions just to drill down. For example, which kind of tools would improve your process? You can type in one or more of the following, or you can just type in one that would be your preferred tool if there was just one additional thing. Notice that I delineated clinical staff in that first tool. Is this a tool that's just for nurses? And that's really where we need the most support, or do we really need a CNA specific tool that would look obviously very different? We've had fun working with interview scripts and developing little scenarios that, again, you could do in a staff meeting, sort of sample, this was the right way to handle this situation and it worked really well versus this is how we used to handle it. And it seems like a very simple thing, but those scripts were very powerful when we've used them in the past because it helps to change the culture.
B, E, C, D.
Yeah, kind of across the board.
A little bit of everything.
Mm-hmm.
What we're thinking that we'll be doing in Oregon is developing a survey that can help really drill down and get the more details about what you need. Because initially we thought, well, we can probably anticipate to some level, but I think the facilities are different and their quality improvement efforts are at different places. So those tools might look a little different. But I would say within one state, within our collaborative, we're going to, in Oregon, work on getting 2 or 3 that can work, probably something off this list and maybe another that we come up with.
We have quite a few for D, actually. And
good.
There's been some conversation in the chat about uniform pain scales. So
good.
But I think that there's certainly an opportunity to create more than one type of tool. So
right, and at a minimum, there was a request to share what are other folks doing in other areas. So that is definitely a role that the Quinn loves to play, is sharing best practices across. Even though maybe everyone's going to keep the tool that they're using for now, nice to be able to share across. So we can do that as well. We got to this a little bit, but let me know. Sounds like we really need tools for different audiences. Would you use any of these tools with residents and family, or is it mostly a tool that works for nurses and some of your other direct care workers? We're anticipating you need all, but do let us know if you were if you're interested in any resident or family tools. Yeah, it sounds like everyone. We were able to anticipate that one.
Again,
Good.
it's that back to the educating,
Yeah.
the family
Yeah.
and the residents.
And it
Yeah,
really,
most
you know, in quality improvement, when we focus on a topic like this, it really is, I use the term, we're changing a culture. And the best example I can think of is 30 years ago, the way our public had, you know, sort of smoking as people smoke, some people didn't smoke, the acceptance level, all of that, versus over time, the way that we've sort of changed the way we think about smoking. Some people still smoke, a lot of people don't, but it's just that it wasn't just the doctor that said, I don't want you to smoke anymore. It was commercials, and it was the American Cancer Society, and it was your grandkids reminding you, and it was the boss at work that changed the policy around smoking, and that's what this will take in order to change the culture on pain. Is there's a public perception that is changing around us, not only in long-term care, but you probably heard the president speak about it last week, and if you saw the Super Bowl, you saw advertisements for pain medicines and side effect medicines. So this is in the news, and this is in our culture, and we're sort of at the cutting edge of this work now. Okay. Any questions about our general, you know, just this topic today? Was there something that came up that wasn't clear? Seems like people were typing in along the way, so I don't think there's any unmet
Not so far, but we do have a
questions.
few people typing,
Good.
so
We'll leave some time for typing.
we can open the line too if we want.
Ladies and gentlemen, if you have any questions, please press 1 on your telephone keypad. Again, if you have any questions, please press 1 on your telephone keypad. Our first question comes from Lorraine Westendorf, Good Samaritan Society. Go ahead.
Oh, I'm sorry, I did not press 1. I don't know.
Oh.
Sorry. And thank you. But this has been very helpful, I'll say. I think this is very interesting and great information. I appreciate the time.
Good, thank
Thank
you.
you, Lorraine.
Thank you, Lorraine.
Our next question comes from Annabelle Redonda, Maryville, New Hampshire. Go ahead. Annabelle, your line is live.
Annabelle, did you have a question? No, it may have been as the previous caller. She didn't intend to push the 1.
Ladies and gentlemen, if you have any questions, please press 1 on your telephone keypad.
And as we have in our previous webinars, I think most folks feel more comfortable typing their questions into the chat. So that's fine as well, if you prefer to do that instead of asking a live question. I think while any additional questions are coming in, we'll go ahead and just finish the last couple of slides just to make sure we end on time. So question about webinar series. We've not necessarily done the webinars in a series before, but we are welcome to do additional webinars, either an individual or in a series. Is there other topics that we should consider? More on pain, a completely different topic. Really, I know urinary tract infections are something that a lot of folks are working on. Any other topics that you're interested in, just type those into the chat as well. And also feel free in the evaluation, there's a comment section. You can add any additional ideas if you'd like. I'd love to get your feedback on what your needs are. A quick announcement for Oregon folks that are participating in our collaborative. As we've been teasing during this webinar series, our next steps is tool development. We're going to be calling out to each of the leaders in our collaborative to be doing that tool development, and of course then having people reviewing that and work on those tools together. We're also going to do a spring face-to-face meeting. We don't have a date for that yet. Spring, summer. It feels like spring because it's not raining here in Portland, but so stay tuned, Oregon, for a date on that. And then, of course, we are adding within our work with nursing home and quality improvement, we're adding infections around C. diff and trying to prevent C. diff infections. We also work with hospitals, of course, on that serious and usually often preventable C. diff infections and how to manage it. So stay tuned for additional information about working with us on improving C. diff rates and decreasing those infections. And these are my fearless leaders who keep this work going. Leah, of course, is the project coordinator, and Tyler, also our project coordinator, and appreciate all their work. They are the leads and the team behind this, and Sharon and I appreciate them helping us get together, get a good picture of us so you could all see what we look like and get this information out to multiple states. So thank you both, Leah and Tyler. And then don't forget to fill out the evaluations. We take that, of course, very serious. I want to make sure we hear from you what's working, what's not. So thank you so much. And I believe that is all. Thank you so much for participating today, and we look forward to speaking and working with you very soon.
Have a good afternoon.
Thank you.